Bismillah ar-Rahman ar-Rahim. Our lecture will be about the cerebellum. At first, we will discuss the anatomical and functional parts of the cerebellum and its efferent and efferent pathway. And in the last chapter of this lecture, we will discuss what will happen if there is an abnormality to the function of the cerebellum. Anatomically, the cerebellum is divided into three lobes by two deep fissures, into anterior lobe and posterior lobe and flocculonodular lobe, so that it is three parts. This is from a cross-sectional view. This is the anterior lobe, and this is the primary fissure, and this is the posterior lobe or caudal lobe, and this is the flocculonodular lobe. This is from cross-sectional view. While from a longitudinal view, lying in the center of cerebellum, narrow band called the vermis. Vermis means in Greek means worm. It is a worm-like. And this is the vermis, narrow band, which is concerned mainly with the axial part of the body, where control of the muscles of hip, shoulder and neck is located. On each side of the vermis, and on each side of the midline of the vermis, was called the intermediate zone of the cerebellar hemisphere. This controlling the distal parts of upper and lower limbs, and also the facial region control muscles are located. And lateral to it, it's what's called the lateral zone of the cerebellar hemisphere, and it's controlled mainly with the planning of the intended sequential movement. Again, this is the anterior lobe, this is fissure, this is posterior lobe, and this is the flocculonodular lobe. Okay. Intermediate zone also, we said, is controlled distal portion. Also, there is a deep cerebellar nuclei, dentate, interposed, and vestigial nuclei, three types. Regarding the cells, they are composed of Purkinje cells and granule cells, that we will come histologically later. These are the vestigial nuclei. This is the dentate nuclei. It is means a tooth-like, and other is interposed nuclei. These are the deep cerebellar nuclei. Again, the topographic presentation, we said that the axial portion of the body, shoulder, trunks, hips, in the vermis, in the midline, and we said that the vermis means the Greek of worm, whereas the limb and facial region distally lie intermediate zone on each side of the cerebellar hemisphere. Coming to the cerebellar cortex. Cerebellar cortex, there are three layers. The first is molecular layer, the second is a Purkinje cell layer, and the third is a granular cell layer. The molecular layer is above here. It's composed of the axons of granule cells and synapsing with the dendrites of Purkinje cells. Axons of the granule cells and dendrites of Purkinje cell. The second layer, Purkinje cell, it is the middle layer of large neuronal cell bodies, and which is noticed here, large neuronal cell bodies. These are the Purkinje cells. And deeper, these are the granule cell layers, which are called granule cells. These granule cells are the deeper, the deepest layer, granule cells. Regarding its function, Purkinje cells utilize GABA, so that it's an inhibitory role to the cerebellar nuclei, while the granule cells, intrinsic cell of the cerebellar cortex, they use glutamate as an excitatory neurotransmitter that excite the Purkinje cells via axonal fibers called parallel fibers. Also, we have what's called basket cells. These are inhibitory interneurons. They utilize GABA to inhibit the Purkinje cells. And we have two types of fibers: climbing fibers, arising from the olivary nucleus, using glutamate and aspartate to excite the Purkinje and cerebellar nuclei, and mossy fibers that enter the cerebellum. All other axons fibers got cerebellum of the cerebellar nuclei. This is the molecular layer. This is the Purkinje cell layer. and this is the granular cell layer, and this is the climbing fibers, and these are the mossy fibers. We have afferent and efferent pathways from the brain. Afferent pathways from the brain: cortex, the cortico-pontocerebellar pathway, originate in the cerebral motor and the premotor cortices, and also in the cerebral somatosensory cortex. From the brain stem, we have olivocerebellar tract from the inferior olib, also vestibulocerebellar tract, some of originated from the vestibular apparatus itself, and from the brain stem vestibular nuclei, and also reticulocerebellar from different portion of the brain stem reticular formation. Also we have spinocerebellar tract, dorsal spinocerebellar, ventral spinocerebellar tract that terminate in the vermis and the intermediate zones of the cerebellum on the same sides of its origin. Signals come from the muscle spindle, Golgi tendon, tactile receptor of the skin, and joint receptor, so it's mainly concerned with the proprioception. All these signals apprise the cerebellum of the momentary status of muscle contraction, degree of tension on muscle tendon, and position and rates of movement of parts of the body, and forces acting on the surface of the body. The ventral spinocerebellar tract terminate in both sides of the cerebellum. It receives less information from peripheral receptors. Instead, they are excited mainly by the motor signals arriving in the anterior horn of the spinal cord. Thus, this ventral fibers pathway tell the cerebellum which motor signal has arrived at the anterior horns. Spinocerebellar pathway can transmit velocities up to 120 per second, which is the most rapid conduction of most pathways of the central nervous system. Coming to the efferent pathway from the cerebellum. Nervous system uses cerebellum to coordinate the motor function at 3 levels. First, the vestibulocerebellum, and this is mainly the function of the small flocculonodular lobe. We saw it earlier. That's lying behind the posterior lobe in the cross section and the some adjacent portion of the vermis. It provides neural circuits for most of body equilibrium. Nearly everything called vestibule is mainly concerned with coordination and equilibrium. It receives vestibular input from both the semicircular canal and from the vestibular nuclei of the brain stem, and send fibers back to the medial and lateral vestibular nuclei. It also receives visual input from the superior colliculi and from the visual cortex, so that it's what's concerned with the visual spinal reflex we discussed in the motor system. The latter via pontine nuclei forming cortico-pontocerebellar pathway. Well, of course, when there is a lesion in the vestibular cerebellum, there will be cause disturbance in balance and gait and in coordination. The second is spinocerebellum. This consists of most of the vermis of the posterior and anterior cerebellum, plus the intermediate zones on both sides of the vermis. The vermis receives fibers from the trunk, we said, and the proximal parts of the limbs, as we said also that the intermediate zones for the more distal portion. Each cerebellar hemisphere receives 2 types of information from the cerebral motor cortex and from the midbrain radionucleus, telling the cerebellum the intended sequential plan of movement in the next few fraction of a second. The second type, feedback information from peripheral part of the body, especially from the distal proprioceptors of the limb, telling the cerebellum what the actual movements result. So that after the intermediate zone of the cerebellum compared the intended movement that reached in part 1 from the cerebral motor cortex and compare what's happened really with the actual movement, the deep nuclear cells of the interposed says corrective output signal back to the cerebral motor cortex through the rear nuclei in the thalamus, and second to the radionucleus that give rise to the rubrospinal tract. So that there is the cerebellum plays a corrective and role of this motor signal. It compares the intended the information from, as we said, from the motor cortex about the intended sequential and feedback from the peripheral parts of what actually happens, and compare between them, and accordingly it will send a corrective output signal. The rubrospinal tract in turn joins the corticospinal tract in innervating the anterior horn of the spinal cord gray matter, controlling the distal part of the limbs, particularly the hands and fingers, providing smooth coordinated movements of agonist and antagonist of distal parts of distal limbs for performing purposeful and patterned movements. Still to come, what's called the lateral zone, cerebellar light zone, lateral zone. On each side of the intermediate zone, the rest is called, we said it's the lateral zone. This is functionally called cerebellum or cerebrocerebellar lateral zone. Consists of large lateral zone, have no direct input from the peripheral parts of the body, or communication the premotor and the primary association somatosensory area, transmits output information in the upward direction back to the brain, function, planning the sequential movement in the next fraction of a second. Second, the timing of the sequential. Without this timing capability, the person become unable to determine where is the next sequential movement need to begin, so that begin either too early or too late, so that it will cause pass pointing or discoordination. Destruction of the lateral zone of the cerebellar hemisphere along with their deep nuclei, the dentate nucleus, can lead to an extreme coordination of complex purposeful of the hand, fingers, feet, and we will come to it later in the abnormalities of the cerebellum. Actually, we have many symptoms regarding cerebellar abnormalities, or the destruction of a small portion of the lateral cerebellar cortex seldom cause detectable abnormalities in the motor function, especially the ipsilateral side. However, to cause serial and continuing dysfunction, the cerebellar lesion usually must involve one or more of the deep cerebellar nuclei, which was three types: dentate, interposed, and fastigial nuclei. First type is what is called dysmetria and ataxia. Dysmetria is also called pass pointing, and we examined it in the lab when there is a movement of the finger so that it overshoot the target, the intended mark. When we make our finger and with the examiner finger and the nose and moving the finger so that the person with abnormal cerebellar function, it will not overshoot the target, it will not reach to the examined fingers. Also, an uncoordinated movements, ataxia, over the patient gait by widened base and high steppage gait, as well as staggering and lurching from side to side. Dysmetria ataxia can result from region in spinocerebellar tracts. This is ataxic gait, sways to the right in standing position, steady on the right leg, and steady. This is the ataxic gait. Pass pointing means absence. In an absent cerebellum, person move its hand or some other moving parts of the body considerably beyond the point of intention. It's called also dysmetria. We discussed it previously. Third is failure of progression, dysdiadochokinesia. It's three, a combination of three words: this bad, diadocho receive, kinesia movement, so that impaired ability to perform rapid alternative movement, and meant by making the hand rapidly up and down in the examining hand, this in the lab. Fourthly is this arteria. The formation of where depend on rapid and order succession of individual muscle movement in the larynx, mouth, and the respiratory system, lack of coordination among these, and inability to adjust in advance either in the intensity of the sound or the duration of each successive sound caused jumbled vocalization with some syllables loud, some weak, some held for long intervals, some held in short intervals, and the resultant speech is unintelligible. This is called dysarthria. The type of tremor here is an broad, coarse, low frequency tremor, an intentional tremor, not resting tremor, amplitude of which increase and extremely approaches endpoint of deliberate and visually guided movement. Also there is a cerebellar nystagmus. Nystagmus, it's rhythmic, rapid, jerky movement of the eye. Tremor of the eyeballs occur especially when the flocculonodular lobes of the cerebellum is damaged. In this instant associated with loss of equilibrium. Also, the abnormality here is hypotonia, decreased tone of the peripheral body musculature on the side of the cerebellar lesion because there is no crossing for the cerebellar tracts. Hypotonia results from loss of cerebellar facilitation of the motor cortex and the brainstem motor nuclei. That's all for the cerebellum. Thank you for listening.